How many people are familiar with the criteria for OCD? Okay, so few. So there's a difference between OCD and compulsions or obsessions related to a trauma. So someone who had a home invasion and checks the windows and doors every night, or if anybody works with the military, like all my military people do like a perimeter check several times a day and night, where they go through and they check the doors and the locks and make sure everything's locked down. They wake up in the middle of the night, they hear a sound, they go do another check. That's really post-traumatic stress disorder. That's not OCD. So it consists of frequent unwanted bad thoughts that are ego dystonic, meaning they're not you. You know that this is weird or unpleasant. You don't want to have it, but you can't stop doing it. So it's not like you're obsessing about your hot neighbor and you're like, oh, they're so cute. Ooh, that's an obsession. It can be an obsession, but it's not unwanted and it's not OCD. And frequent unwanted behaviors. So like rereading, repeating, checking, counting, having to do things in a certain order. Things that cause significant distress or they interfere with your functioning or last greater than an hour per day. So it might be that they're not spending that much time on it, but it's really causing a lot of distress. Or it might have lower distress, but there's people with OCD where they're like, I can't get that song out of my head. Like we've all had that experience, but the way I think about people with OCD is they have a stickier brain. So they hear that song, and whereas we might hear it for repeating in our head for 5 or 10 times or a really catchy tune, a lot more, but they literally, it's like that record is on the groove and they keep hearing it over and over again. So part of OCD treatment includes education about the nature of OCD, because a lot of people have this terrible shame and are very embarrassed about it. So we really need to educate that, hey, this is biologically based. It's probably mostly genetic, and it's not because you're a bad person. So I had a client come to me where they were raised Catholic, and when they started having sexual urges, they felt so guilty about masturbating that they had to create like this whole idea that it was like something that was not pleasant. So they started choking themselves, which is, some people get off on that kind of paraphilia type of thing. But she was someone who it was all wrapped up in her OCD, and she really met criteria for OCD. She had a lot of other obsessions and compulsions, but that was one. And she had been, she also had intrusive thoughts of harming herself and of killing herself. And she would see herself, but it was completely ego dystonic. She didn't want to. And she kept getting hospitalized. But she didn't need to be hospitalized. She just needed OCD treatment. And she would go to therapists, and therapists would say, oh my gosh, that's terrible. Wow, how does that feel? And she'd say, it feels terrible. It's ruining my life. Can you please help me? And they'd say, oh, well, how do you feel about it? So obviously that was not helping her to get any better. So we educate that it's genetic. And that it's, we also talk about how it's ego dystonic. So we all have things that we do that are kind of OCD-ish, right? Or many of us do. So hold the question for just a minute. So for example, it might be that I don't like to have dishes in my sink. But let's say I was rushing to leave San Francisco and come here to prepare to present to you guys, and there was a dish in the sink, and I was going to be late. If I stayed and I had to wash it, and maybe wash it 2 or 3 times, well, that's probably OCD, right? Because it's not really, it's working against me. It's not working for me. It doesn't really make any sense as opposed to a preference, you know? So if I have a dinner party and I stay up till 11 o'clock doing the dishes, even though I have to get up really early, that's a little more on the compulsive end of things, right? I'm sorry, now what was the question? Oh, here.
I have a client that her OCD is not genetic. The onset was 3 years ago when her sister, who was away for college, her dog died, and she felt very guilty, and she developed thought OCD that she's going to molest children. She also developed the compulsion that to stop the thought, she has to turn her head, look on the ground, and the thought will go, and it went on, and that's for hours a day. We worked on the trauma, we cleared the trauma, the OCD subsided, and I'm also specializing with exposure and response prevention by Edna Foa. So we do EMDR with the exposure, but it's not in remission, and it's not genetic.
Okay, I'm going to actually beg to differ. And the reason why I beg to differ is, and we're going to get to this as we're going through the criteria, is OCD can develop anywhere across the lifespan. So there's people who grow up with OCD, and there's people who have adult onset. And it often comes on related to stress or a trigger. One of my childhood friends went to go see The Exorcist, which was a really scary movie. Yes.
Can you repeat the question, please?
Oh, yes, thank you. So, so the question was that one of the participants has a client who developed OCD following the death of her sister's dog, and the participant was saying it's not genetic because it developed at that time. Then they treated the trauma, and the residual OCD symptoms didn't go away.
No one in the family has OCD.
And no one in the family has OCD. Just because no one in this generation has OCD doesn't mean they don't have the gene for it. Yeah. So it might be, you know, aunts, uncles, grandparents, you know, sort of thing. And so OCD can develop any time during the course of the lifespan. And, you know, this person who was a childhood friend who developed it related to seeing The Exorcist, which is a very scary movie. I slept with the light on after watching that movie for like 2 months because I saw it when I was 12 or something. You know, so it can start with a trauma, but it doesn't mean it's caused by a trauma, because if it was really caused by the trauma, once we reprocess the trauma and all the triggers related to it, it should go away if it's not really biologically based OCD. Okay, so that's kind of how we think about it. And you see, I love your example because it gets tricky, because they can be really intertwined. You know, if you have a traumatic experience, they can be intertwined.
And it's hard to figure out further generation because the grandmother is raising them. She's now 19. No contact with the parents. There is no extended family there. So I cannot figure out.
Yeah, it's hard to figure out the genetics because she was raised by the grandparents and the family's not there. Yeah, so it's hard to figure it out. Yeah. So, but we can just assume that, you know, because that's what the research says about OCD. So we talk to people when they first come in about the model of exposure and response prevention, and I actually treat that. The participant mentioned Edna Foa, exposure and response prevention, and that's something I teach all clients who have OCD, because I want them to have a tool they can do when they're at home. So we do exposure and response prevention. So exposure and response prevention is where we're going to go through it a little bit more in more detail in a little bit longer. It basically comes out of the work of Stanfel and Levis from 1967, and Borkovic and Hugh that Christy was talking about, working with Borkovic, also did a lot of work on that, as well as Edna Foa. And exposure it's basically you're exposing yourself to your fear and you're not doing the response. So for example, you would teach the client to put on the kettle. This is for someone who checks the stove. Put on the kettle, go into the next room and watch a television show. That would be like the first step of an exposure. So you have the water boiling, they're worried that the stove is left on and they're not watching it. And then we get them to move up the ladder to do something a little harder to the point where they can go to the local cafe and leave a pot of water boiling while they're there. And go have a cup of coffee or a cup of tea.
Isn't that a good idea?
Yes. It's a great idea. My brother is a chef, and one of the things that he makes is sauces that are based on a 72-hour stock reduction. Okay? So stoves are made to be left on. He leaves the stove in the restaurant going when he's not there for 72 hours.
But with water, if you could start to burn the pot.
Okay, with water you could start to burn the pot. We're not telling them to go to the cafe for 5 hours.
Okay.
You put on a big pot of water and you go, half hour, hour. It's not going to all boil away. Yeah. Just as an aside note, I did it one time because I'm not OCD enough. I wish I was a tiny bit more OCD. I went dancing at my local place and I put on some artichokes to boil. And I'm dancing and having a great time. There's a place we go in the afternoons in San Francisco called The Ramp. I don't know if anybody from around here goes there. And I thought, I wonder if I left those artichokes on. And I thought, oh, well, it'll be okay. And I forgot about it. And I went back and the water was all gone. The artichokes were burned up. And the pot was pretty much ruined, but that's all that happened. So,
It happened to me like that, that's why.
the participant's saying it happened to her like that. Yeah. So we teach about exposure and response prevention. We teach the client how to do it. And then we also, do EMDR therapy where we add the bilateral stimulation while they're doing some of these exercises. And we're going to go through this in great detail. So there's also OC spectrum disorders or sister disorders, and there's a lot of comorbidity that people have. So for example, you might have someone who has OCD and hoarding, trichotillomania, excoriation disorder, compulsive nail biting is a sister disorder to OCD, Tourette's, eating disorders, and I'm almost sort of thinking like along that spectrum there, somewhere past Tourette's, might be ADHD, and it might be autistic spectrum disorders.
How does Tourette's go with OCD?
I'm sorry?
How does Tourette's go?
How does Tourette's go with OCD? So please, if you, we're sort of asking to hold questions for now. Yeah. But Tourette's goes with OCD because it's very similar, actually. If you've ever worked with someone who has Tourette's. Mm-hmm. So the famous part of Tourette's is that people are shouting out obscenities, like the F word, right? But the criteria for Tourette's is you have one or more vocal tics. And often the vocal tics are like, you may not be screaming obscenities. And then they might have another tic, like a lot of people have eye blinking. So you might have just those two. And then they often have sort of OC tendencies, and many people have Tourette's and OCD. So the part of the basal ganglion, which we're going to be talking about as well, so there's a part of the basal ganglion that has to do with thinking, and the substantia nigra, and then there's a part that has to do with behavior. So the Tourette's is more affected by the behavioral part as opposed to the thinking part. But I've worked with a lot of people with Tourette's, and every single one that I have had has comorbidity of OCD.
So
I don't think that,
exposure?
We're going to talk about how we work with them. So just hold on with that. So there was a number of changes in DSM-5, and we're not going to go through this. If you want to read this on your own, you can. There was some changes with that. I want to talk. So now we're going to talk about the exposure and response prevention. So the idea of exposure and response prevention is, what happens is the person starts to get anxious, their anxiety goes up, and typically what people do when they have any kind of anxiety, including OCD, they start to get anxious and they're like, this is highly unpleasant, so I'm going to avoid. And when they avoid, their anxiety goes down, but their fear goes way up. They become much more fearful. So they're in this anxiety triangle of always feeling anxious and avoiding, and they get usually sicker and sicker. So what the exposure model is that you have the person avoiding and do the thing they've been avoiding and allow the anxiety to rise. And then it'll peak and it'll come down. And then the next time they're in that situation, let's say we've got a stove checker. The stove checker, we say, okay, postpone checking for 10 minutes. They're like, I don't know if I can do that. It makes me really anxious. That's really scary. We say, just don't check for 10 minutes. So they get really anxious, their anxiety comes down, and then we do it again. And next time the anxiety peaks sooner and comes down sooner, until pretty soon they get to the point where it doesn't bother them and they don't need to check. So for OCD, people have these very high levels of anxiety. And it's really interesting because they're really able to tolerate the exposure and response prevention very easily. But what we do with EMDR is a little bit different. Thank goodness, because it's a lot easier. So this is more like what it looks like with EMDR. So we do the same thing. We'll have them, okay, picture leaving this stove on and not checking. And they'll get really anxious, and then it'll come down really quickly and stay down. And then we'll do it again. And then we'll do it again. And we're adding bilateral stimulation in while we're doing this. And what happens is they get much better really quickly. And the OCD, it's almost like magic. It's so amazing. I had a young man who had been obsessing about I mentioned this yesterday. He'd been obsessing about thermonuclear war for 15 years, half of his life, because he was a young man. So he'd been obsessing about thermonuclear war for 15 years. And then there was all that stuff that was happening last year with the president and Kim Jong-un, and was very, the client was really having a lot of obsessions and saying, I'm really concerned we're going to die. I'm really concerned about this. So we did EMDR therapy on the obsession, and he came in 2 weeks later. He says, I'm not obsessing about it anymore. I don't know what happened. It's really weird. It's not happening. I should be obsessing about it right now because it's more eminent than it's ever been in my lifetime. But I'm not.
Are you doing the whole protocol?
Yeah, we're going to go over what we do. The question is, are we doing the whole protocol? We're going to go over what we do in very specific detail. So clients need to stop doing their compulsions. So we need to educate them that, about neuroplasticity, and the more we check the stove and the more we wash our hands, the worse our OCD gets. We also talk to them about when people have OCD, we have to do behavioral practice and they need to overdo it. So for example, it is not unusual for someone who's in OCD treatment to have them do a 24-hour no hand wash, or a 48 or a 72-hour no hand wash. And I heard like a from the audience. And that's because that's not what we normally do, right? Normally, most humans, that are living in society, we do a hand wash after bathroom and before eating, at the very least, right? Or if we touch something really icky, we might wash our hands. And that's pretty standard average person, right? But just imagine you have a client who's washing 9 hours a day. And their skin is raw, pink. I mean, you can always, when we're doing an assessment on a client coming in, we look at them, right? I can see the OCD hand because the skin is just rubbed away, So we don't do that. That's not the very first thing that we do, right? That's something we do over time as we work up to it. So we have the client put a kettle on the stove and go to a cafe, or we have the client eat something after touching something dirty, like the toilet. So I'm going to have to put this down. Maybe I'll put this stand. Oh. Oh dear. This is funny. Can I have the cowboy hat?
What is that?
The paper. Okay, so does everybody see what this is? We call it a cowboy hat, an ass gasket. So when I'm OC Foundation trained. When I did my training with OC Foundation, they had everybody raise their hands and they said, how many people of you used these? How many use them? And they said, you all have OCD. And I don't actually think that that's true. But the idea is like, we don't really need this, right? That's really kind of a obsessive compulsive thing to have. Do you mind if I have you come up and help me?
Oh, sure.
I just need someone to hold this for me because I need to demonstrate. So we have a little tape to show us kind of where we have to stand. So maybe this, yeah. Okay. So the idea is with the client, we're going to just pretend that this is a toilet seat. Because we don't have a toilet seat in here. I should probably get one that I can bring to these trainings. But that's a lot to lug around. So what we do with the client is we actually touch the toilet. And then we also lift it up and touch the icky side and then touch the porcelain down here. Okay, that's good. And then what we do, because it's really important, because what will happen with clients is you'll do that and then they'll go in the office and they'll sit there with their hands like this on the chair, like they'll sit like this, perched for an hour. And you'll say, are you doing that to avoid touching yourself with your hands? Oh no, I'm more comfortable like this. So which is not true. So we have to do a little bath, a germ bath. So we have to touch ourselves after touching the toilet, and we touch everything and just, get it all over, really good. And then we touch the mouth. And then usually we would eat something with those dirty hands. We'd pick something up with our hand and eat it. And then we add in the bilateral stimulation. Well, it was really interesting. At the hospital where I did a lot of this, they would clean the restrooms before group. Not on purpose, it just worked out that way. So they were clean. But, I probably wouldn't do it if the toilet was covered with, poo or something.
You probably wouldn't do it.
But actually, the very interesting thing, because we would also touch door handles and sinks and the kitchen floor and sponges and whatever the OCD person was having difficulty with, we would touch. And the interesting thing was there would come waves of people where I would have people where they were really not very germ phobic. And so we wouldn't be doing any germ exposures for a while. And I would get sick. And I got less sick when I was doing the germ exposures and touching all this stuff probably because of my microbiome, which we're going to talk about in a minute, we were, bringing it up more. Can you guys hear me okay like this?
Yeah.
I have a big voice. So we want to remind the client about that response prevention graph, the first one. So what goes up must come down. This is our opportunity as therapists to be creative. We can do, it can be really fun work that we're doing. I know it sounds scary. And the first time, I remember Dr. Dora Wong, we were taking a field trip to the bathroom with the clients, and she said, okay, we're gonna touch the toilet. And after, I stood in the corner as far away as I could. And afterwards I said, wow, you're so brave. I can't believe you did that, Dora. That's amazing. And she said, well, Priscilla, you have to do it too. And I said, oh, no, I'm never going to do that. And she's like, but you have to. So because you have to model it for your client. Because if you're afraid of it, you're showing your clients non-verbally that it's not okay. So we have to do it too. If you can remember, this is part of the in vivo component that we're doing with EMDR therapy. If you can get the client to do it immediately, get started right away. So we don't want to have the client talk about doing this and then wait session after session after session. The sooner they can dive in, the less anticipatory anxiety they're going to have. And anticipatory anxiety is so painful to people. So just imagine they're thinking, 3 weeks from now, I'm going to have to go there and see Dr. Marquis, and I'm going to have to go touch that. And they'll be obsessing about it from now until then. It's much better if we can say, let's just go in the bathroom right now and do it. We have to model the behavior, and it's really important to practice ahead if you're anxious. And you can do your own, can't do that, right? Can do your own butterfly hug, where you're doing bilateral stimulation to calm yourself down. Or if you really have a lot of fear and you feel like you can't handle it on your own, go get your own therapy. This is something that I'm always kind of preaching about getting, get your own therapy. It's an important thing. It's an important piece of our work so that we can really be fully present with the clients. Yeah. I'm in ongoing EMDR therapy myself, and I find it really, really helpful. My first EMDR session in practicum from the workshop training was public speaking anxiety. So guess how well it worked. Okay, so here we go. I'm modeling it. This is actually,
I don't see your hands on me.
I'm drinking out of that. It's a drinking fountain. That's actually at the Exploratorium in San Francisco. It's a water fountain that is made out of a toilet. So the adaptive information processing model, how does this apply to OCD spectrum disorders if they're biological? How do we apply the adaptive information processing model? So the way we think about it is the experiences within the disorder. Somebody had asked earlier, isn't it traumatic to have OCD? Yes. With EMDR, we talk about having a large T trauma, where we have a very seriously traumatic experience. And then we also have small T trauma, which are those daily events that zing the nervous system and are, even though they might be small, can add up over time. So when people who have OCD, they're experiencing this like both large and small T. So people with OCD, they have these incredibly sticky minds. So they can remember 17 years ago, I stepped on this thing and I thought it was a needle. Or 7 years ago, I called these people and I made a complaint, and the next time I went into the place, the guy wasn't there, and I think I got him fired. So I keep calling the place and checking and going by there and trying to see if he's there to check. if I got him fired. Or there's the person who has hit and run OCD, where they think they ran someone over. You know, you're driving along, you feel a bump. We all feel that. There's people who like have to circle back or get out on the freeway and search for dead bodies because they think they've killed someone. And it's not psychosis. They're not psychotic. Part of them knows this isn't real, but I can't stop myself from doing the compulsion. So we reprocess these large T and small t experiences that are related to the disorder. We get brain change through neuroplasticity. So the more we treat OCD, the less OCD the person gets. The OCD gets smaller and weaker, and we get stronger. And, you know, because of the psychoeducation, I've had some clients who really just sort of embrace this. So I had one guy who, he was like, you know, I really want to go after my OCD. And I noticed I weigh myself twice a day. Is that normal? Is that what everybody does? And in fact, because I'm not sure if I've done it right, I weigh myself twice a day 3 times. And I take the best weight out of the 3. Now, to me, that sounds OCD. So what he decided to do, and this was his own choice of what he wanted to do, was after doing the OCD treatment, in order to keep going after brain change, he said, you know, I'm just not going to weigh myself for a couple of weeks. And I might be a little anxious over it, but I'm just not going to do it. And then he decided, well, how often is it really good to weigh yourself? So he decided once every 2 weeks he would weigh himself once and no more. And then he started, you know, kind of ramping up and weighing himself more. And he said, okay, that's it. I'm done weighing myself. I'm not going to do it anymore. And this was not, you know, he wasn't someone who had an illness or was overweight or underweight and needed to weigh himself. So he just stopped. So typically when we process with EMDR therapy, we go in on this target of this trauma, and then we go through these channels of association, right? So we'll have a car accident, and then it reminds us of a time we had a bike accident, and then we go back to target, and then they go down another channel of a separate car accident, and so on, right? We just go with whatever ones of these channels are opening up. So typically we do that with EMDR therapy, but with OCD obsessions, they're not real and they're not based on trauma. So these are, you know, they're kind of like a house of cards. So what we do, it's this like little self-contained neural network that doesn't connect to anything else because it's not really based on real experience. So what we do is we return to target really frequently. So with the thermonuclear war, what we did was we came up with a worst case scenario. We decided we weren't going to do like everybody's dead because he said that's not a problem. If we're all dead, we're dead. And this guy's belief was, you know, like death is not a bad thing. You know, we're just dead. You know, if you're going to suffer, it'll be quick. So what we decided would be worse would be to like have, you know, some sort of radiation sickness and to be really sick and maybe losing loved ones. So that was his worst case scenario. So we started with him thinking of the worst case scenario, reprocessed into, you know, did a set of eye movements, take a deep breath. What are you noticing now? Oh, it's a little bit better. And then we would bring him right back to target. Okay, let's go back to that worst case scenario. And we would keep coming back to the worst case scenario every time because we're not trying to associate to other things. We're just trying to clear out that one little neural network.
It doesn't sound like you do the standard protocol, you're just focusing on that scenario.
So the question is, it doesn't sound like we're doing the standard protocol. You're just focusing on that scenario. So for obsessions with OCD, we do not do the standard protocol. That is a good observation. Yeah. So often they just collapse like a house of cards, and it could be 1 or 2 or 3 sessions for a really long-held obsession to just go away. Now, but because of this biological nature and the sticky brain, the client may latch onto a new obsession. And so we just target the new obsessions as they come up, and we really want to be encouraging to the client because clients can get discouraged about this. And they can feel like, oh my, this is never going to go away. So we keep reminding them about, the more we fight the OCD, the weaker it gets. The more we change your brain, the less your brain is an OCD brain. So that's kind of how we explain it to them to keep them involved. So we really have to educate clients and get them on board with the idea that this is genetic. And the EMDR therapy can really help to greatly decrease reactivity to these obsessions and compulsions. But the clients also have to do homework. So this is another change from what's typical with EMDR therapy, is that people generally, we don't make them do homework because whatever needs to happen just happens organically. The changes just fall into place. So we may have to set up homework with clients. So for example, if someone's coming in and we're working on an obsession of thermonuclear war, we might have them say, okay, so if this comes up between now and when you come in again, I'd like you to try postponing thinking about it. Because with obsessions, the compulsion is to think about it. Does that make sense? They keep going back and like going over it and revising it and thinking about it and what if this and what if that. So we would have them say, I'm going to postpone for 10 minutes and just call it OCD. It's just my OCD. It's not real. I don't need to think about it. I'm going to postpone. Sort of like a little bit of a brief exposure. And then if it still comes back in between session, we might have them do a writing exposure where they write about it until their anxiety comes down. Or if it's someone with a check-in, we might say, okay, let's have you postpone 5 minutes before you start your check-in. Or let's have you see if you can just, if you feel like you haven't checked the lock, just leave it. Don't check and go, try and go. Just say, that's my OCD, I don't need to check, and just go to work. And see how long, and if you feel like you really have to, go sit in your car and wait 10 minutes to see if the anxiety will come down. Because often it will. With OCD, it can be really quick. And the goal that we have, I think Christy talked about this earlier, anxiety makes our life very small. People avoid, they're not able to be free. A lot of my folks with OCD, they don't live their life. Like they can't do fun things because they're just in this OCD world all the time. So we want our clients to be able to be free to live their life. That's our main goal always with EMDR. So history taking for OCD, we take a typical history. One thing I find really helpful is the Yale-Brown Obsessive Compulsive Scale. It's a clinician-administered OCD scale, and it has this whole list on there of all the different types of obsessions and compulsions. Religious, contamination, counting, checking. It's got it all on there, so we don't have to keep that all in our head. We can just go down the list, and it's really interesting because someone may come in presenting with one thing, and then they really wind up having a lot of other things. So it's good to do that and it doesn't take very long. We have to ask specifically about compulsions because people are ashamed. So we want to ask, do you reread things over and over and over again? Do you have to repeat things? One thing that people do is a really sneaky, I call it a sneaky OCD, is where people have, I got this new coat that I'm going to wear for my thing. What do you think? Do you like it? So that's like a normal social question. We would all probably ask that. We're going to do a big presentation. Do you like my coat? You think I look good? Do you think it looks okay? But someone with OCD might do this again and again. And they'd go find someone else. What do you think? I think it's got like a little fuzz on it. What do you think? Does it have fuzz? There's a client who bought a new couch. People with OCD want everything to be perfect. They bought a new couch and had a little scratch on it. So every person who came into the house, what do you think of the couch? Do you notice anything wrong with it? What about this thing over here? Do you notice that? So they're seeking reassurance, and it can go into all different areas. It's really interesting. So I also ask about these other types of compulsions, like skin picking, hair pulling, nail biting, hoarding, because they are these sister disorders. Eating. I've had a number of people with OCD who didn't really have an eating disorder per se because they did not have the body image distortion. They're like, my weight is fine, but I feel like I want to eat healthy, so I'm only eating 1 can of vegetarian chili per day. Every day. That's all I eat. Well, guess what? That guy got hospitalized because of low body weight. But he knew he was losing weight, but he couldn't break the compulsion without coming to treatment. So I got him after the hospitalization. You know, I had another guy who he ate every day 12 eggs, whole wheat flour, a pinch of salt, mixed up and cooked in the microwave. I love to cook. I love fresh food. And when I heard that, I was just like, it was so sad for me. So one of the homeworks we had for him was to eat a sandwich, you know, because he hadn't had a sandwich. That's all he'd eaten. It was so sad. He was not malnourished. I mean, I guess if you're going to pick one thing to eat, that's not too bad. But it was just so sad, you know, and it is sad with people with OCD because it robs them of their joy and keeps them from being able to enjoy things. We also have to ask about embarrassing stuff. You know, it's really interesting. We don't usually as therapists ask like, how many times do you have to wipe after you have a bowel movement? You have to ask. Because they may be using 3 rolls of toilet paper. I had one client who described doing what he called surgery to get the feces out of the anus, you know, by sticking his finger up there, you know. And he had this whole bathroom ritual that had to happen before he could take a shower. Then the shower was for like hours. And so he couldn't leave the house until he had a bowel movement. And then he had to do the ritual. So he obviously was not able to work or go places or do things. A lot of people have sexual obsessions. You know, I had a client who was like, do you ever, you know, picture your neighbors naked and picture them having sex? Not really, not lately. And they said, you know, and it's not something I want to do. They're not very attractive neighbors to me, but I can't stop doing it. It's really embarrassing. Or another client who she had her breasts were a 32A, and if you don't know what that means, it means very flat-chested and small. And her obsession was that her breasts were too large, and that she was going to tempt the priest. And that she was a bad sinner. And so she would go to Mass, and there would always be this struggle, should I take communion? Because if I take communion, I might tempt the priest. So I would never have known that if I didn't specifically ask, like, do you have any, you know, obsessions about your body or about religion or about sex? So you gotta ask, even though. Does the Y box have a list? The Y box has a list, but it doesn't. So that's a good thing to go through. But you know, we may really have to get a little more nitty gritty. Like the Y box doesn't ask how many times you have to use toilet paper, or I ask people how long does it take you to shower. I take 3-minute showers because I grew up in the drought. For 7 years, we had a drought in California when I was growing up. So we used to have to shower to stopwatch. So I'm a really quick showerer. If I need to, I can go really fast. I have clients who, when I say, you know, can you do a 3-minute shower? They have a whole ritual. You know, I have to do this hand. It's got to start with this pinky, and then here, and then I've got to go over it 5 times, and then go to the wrist, and then go up to the elbow. You know, they have this whole ritual that they do. Or they wash their hair every single time they shower. You know, and I don't know, some people may need to if they have really oily hair, but, you know, probably washing your hair every day is not necessary for most humans. Okay. So during the preparation phase of OCD, we do the psychoeducation. We talk about the brain's functioning differently. So people with OCD have these neurological structures in their brain that are wired together that are called the worry circuit. And the more we turn off our worry circuit, the more we change the brain. So we want to tell OCD clients they have this worry circuit that's turned on and it doesn't go off very much. So the more we do the therapy work and the exposures, the more their worry circuit turns off and the more their brain gets changed.
I have a
Yes.
question.
Uh,
Do you have a list or a handout with the more specific history-taking questions that you have learned to ask?
So we take thank you for the question. We take a standard history like we do with all EMDR clients, and then I use the Y box. I think that's a great place to get the specific questions to ask because it really goes through it in great detail, and that will help you. Yeah. So we believe that EMDR therapy is working to change the brain. Now, that being said, this is a biological disorder, and some folks with OCD may need medication. So kind of the way I think about it, if people are coming into therapy and they're doing their work and they're not progressing, and it's been several weeks, I would start to think about getting them referred to the psychiatrist for an OCD medication, which is usually an SSRI. Did you want to talk?
I was just gonna ask what's the recommended.
Yes. So usually SSRI, selective serotonin reuptake inhibitor like Prozac, Paxil, Zoloft, or an SSNRI, which was specifically designed for OCD, which is a selective serotonin norepinephrine reuptake inhibitor, and that's Cymbalta. I think there may be some other ones too that I'm not up on. So those are the most common ones. Some people take clomipramine, which is an older OCD medication. The thing you want to be on the lookout for is if your clients have been prescribed any type of a benzodiazepine, like Klonopin, Ativan, Valium, any of those, that is going to make their anxiety symptoms worse overall for any anxiety disorder. Benzodiazepines are often prescribed by doctors because they make your anxiety go down really quickly. But what do you think they would do to that exposure curve? They can't get their anxiety up, so they can't really do the work. And also, I think benzodiazepines and methamphetamine are the two medications that can block EMDR processing. So now that's often a sticky wicket to try and get a psychiatrist to change their way of practice. I did a lot of psychoeducation with psychiatrists. Sometimes we need to know who our client is, about what does the research say about benzodiazepines and anxiety disorders. But they're contraindicated for panic. A lot of these things, people go to the emergency room and what happens? I'm having a panic attack. Oh, give them some Klonopin. Give them some Ativan. Give them a Valium. And they feel better, and then they go home with their prescription, and then they start hounding their psychiatrist for it. And then now you have two problems. You have a dependence on an addictive benzodiazepine that also creates rebound anxiety and blocks your progress in therapy. And then you have your panic disorder, so it makes it harder. We can do EMDR therapy when people are on benzodiazepines, but it's going to be much slower, and we may have to retarget everything when they get off the benzodiazepines. Okay, so phase 3, assessment. So the assessment phase is where we're lining up the target and getting it ready for EMDR therapy reprocessing. Okay, I always think of this as the 5-minute phase. It's really quick. We don't spend a lot of time on it. So we select a target image of the memory. Remember, the first target is typically the first time the individual started having obsessions or compulsions, then the worst time, then the most recent time, And then the clinician will help the client to target present stimuli such as doorknobs or cracks in the sidewalk. So for those of you who are having questions about the phobia protocol, this is the same for phobia, except that it's the first time you experience the phobia, the worst time, the most recent time. So you ask what picture represents the most disturbing part of the incident now. You obtain negative and positive cognition if you can. It's individualized and it's related to the characteristics of the target event. So the cognition should be related to the target and in present time, self-referent and description of the current belief about the past experience, not a description of what happened at the time of the event. So if we're going through, I am contaminated, some people, like let's say, I remember this time where I stepped on a dirty glove and I thought I had HIV. So some people, their cognition might be, I'm dirty, I'm sick, I'm damaged. Some people, it's really interesting, they might have something more along the lines of, I'm dangerous, because they're afraid of contaminating others. They may be the traditional EMDR, sort of positive and negative cognitions, or they may be more OCD related. And so like a positive OCD cognition that I offer clients is, it's just my OCD, it's not real. It's just my sticky brain going. It's just a passing sticky thought, I can let it go. Germs are healthy and part of what make up our autoimmune system. If I resist my OCD, I get stronger and my OCD gets weaker. So if they have any other memories that happened before, that should say the OCD, the negative in cognition of these targets may have different cognitive domains from the cognitions related to the OCD targets. So that would be, so sometimes, for example, I had a client with really bad OCD who his first memory was mom screaming at him in the car because he picked up something off the floor of the car and was eating it. And probably mom had OCD too. And she was screaming, that's dirty, it's dirty, don't eat that. So his cognitions were, that was before he developed the OCD, but he remembered that as a memory. And he probably would have had OCD no matter what, but it's possible that his OCD took that form of the contamination in part because of the experience. Although there's some research to show that part of the OCD may also be genetic, like the type of OCD we get. So what words best go with that picture that express your negative belief about yourself now, negative cognition? When you bring up that picture of the incident, what would you like to believe about yourself now? Validity of cognition. So this is the scale that we use to be able to rate. When you bring up the picture of the incident, how true to those words, I'm damaged, feel to you now on a scale of 1 to 7, where 1 feels completely false and 7 feels completely true. Then you want to identify the emotion, the subjective units of disturbance level, and the location of the body sensation. So when you bring up the picture or incident and those words, I'm damaged, what emotion do you feel now? Then you ask for the SUD level and the body location. So this is all written, we have like the script in there for you. Yes?
Why are you bringing up I'm damaged if it's not a good cognition?
I'm sorry, that's my brain glitching. No, so this should be
And now healthy?
I'm healthy.
Okay.
Yeah. Yeah, and by the way, hypochondria is often a form of OCD. People who think they're sick all the time and go to the doctor. I had one guy who was referred to me. He was the highest medical utilizer in the Kaiser system. And my chief came to me and said, can you keep this guy out of the ER? He's like, you can see him as much as you want. You can see him every day if you want to. He had had 72 HIV tests. He was married and not having any extracurricular sex. It was his OCD. So we had to get to work with him. The first step was you can't go to the emergency room anymore, ever, unless someone around you tells you they're calling 911 because they think you're dying. So we just took it out of his hands. That was the first exposure. Yeah. Okay, phase 4, desensitization. Use the EMDR protocol for targets in the order of the standard anxiety protocol. So we're using the standard anxiety protocol. First time, worst time, most recent time, and present stimuli. We process the targets in that order. Then for individuals with OCD, it may also be necessary to spend more time processing present stimuli. People have all kinds of funny things that are bothersome to them. I had one client, she spent 9 hours or 12 hours or 6 hours straightening her towels. Now, I like my towels to be lined up too, you know. I like them to look like that. But I don't sit there, you know, when I'm trying to leave the house going like this for hours. That's a little too high, a little too low. So we had to work on the towels with her.
Just a little.
Is this going to be a long question or a brief? Okay.
Pretty short question. So the question is, I'm a little bit confused what you do. Do you process the words first, or do you do what you were talking about before, what the behavior is, and taking them through the BLS?
So the question is,
Yes,
do we
first.
process the worst first, or do we take them through the behavior with the BLS? So what happens is the new OCD client comes in to see me, and we take a history and we give the Y box, and we may not give the Y box the first time because we may not figure out that it's OCD right away. So we may give it the second time or the third time. So we take the lay of the land, we take the history, and let's say we diagnose them with the OCD. So then we would start doing the preparation phase with additional information about what is OCD and what is OCD treatment. And then the answer, once again, is it depends. So the standard protocol would be that we would do the first time, or anything that was happening before, like my client where the mom was screaming at him about eating the dirty cookie off the floor of the car. But it depends, because sometimes somebody's coming in. So like the client who came in with image of the hanging, that kept getting her sent to the ER. And then eventually they kind of caught on, and they're like, she was thinking, she was obsessing that she was going to kill herself. But she didn't want to. She wasn't really wanting to, but she couldn't stop thinking about it. And it was like 24/7. That's all she could think about. So we targeted that first, because I wanted her to stabilize and not have to keep going to the emergency room.
So you asked her what the worst part of having that fear of suicide?
She had an image. It wasn't a fear of suicide. It was, a lot of times people with OCD get these really gruesome images. So they might, it's like horrible, but you know, they might imagine like they've run over a baby, you know, or something like that. And even though they know it's not real, they see the image. And so they'll be like, or they'll be talking to their husband while they're preparing dinner, chopping up the carrots for the salad, and they'll suddenly get an image of like stabbing their husband in the neck. And they'll see the blood, you know. I mean, it can be really intense for people, you know, and it's not going to happen. One of the homeworks we do for people with knife OCD is we have them prepare something that's going to take a long time to chop, and then, because a lot of times they won't use a knife if they're around people. It's part of the avoidance. So we'll say, go chop the salad, and say, honey, can you come talk to me while I'm making the salad? So they can't tell them that it's their OCD homework, because then it's sort of like cheating. You know, if they say, I have to do this because my therapist told me to, you know, so we have to be, like Christy said, a little bit evil. I call it sneaky. Got to be a little sneaky. But so did that answer your question about what we target first? If it's something that's like somebody comes in, they're hand washing 9 hours a day. With him, I actually did do the first time because it was related to the hand washing. But let's say the first time was not related to the hand washing, and it might be, back then I used to check the stove a lot, but I don't check the stove anymore. Now I hand wash. I might choose to do the hand washing first. One of the things that happens with OCD is that sometimes the obsessions and compulsions just shift. Overall, people who've had a long-term OCD, their obsessions become more prominent as they get older, and their compulsions become less prominent as they get older. So famous OCD people, there is David Sedaris. Anybody familiar with him? Hilarious, laugh until you cry author if you haven't read him. He is so funny. And he wrote a story, he wrote a novel about growing up with OCD. And he had all these bizarre compulsions where he would lick things and spin around and touch things and count. And his mother would just sit there with her glass of wine and her cigarette and say, David stopped acting like an effing retard. Like she didn't know what it was. She didn't know what to do. And so like that was her approach of trying to deal with it. So he didn't get any treatment or anything. And then he went to college and started smoking. So an introduction of heavy amounts of nicotine, and the compulsions went away. So probably a combination of getting older and adding nicotine. But if you read his recent work, I do not believe his OCD is gone. He says it went away, but he's highly obsessive still. Yeah. So that's, that's one thing to think about. Okay, now I digressed. So back to the desensitization phase. Are we doing okay, Christy? Okay, good. So when you go back to the original image or incident, notice the words, repeat the negative cognition, the emotion and body sensation, and follow my fingers. So you want to continue with sets of bilateral stimulation until the SED level reduces to the 0. Then we do the installation of the positive cognition, just like we normally do. And then we do the body scan, just like we normally do, to see if there's anything left that the body is holding. And then we do the installation of the future template. So that's standard, right? So if all the targets are reprocessed and the body scan is clear, the targets for that day, we're not going to probably be able to reprocess all of the OCD in one in one fell swoop. So the targets are reprocessed and the body scan is clear. It's often helpful to do future situations, and there may be separate situations where we're doing the future. So I had a client where every time he had sex with his wife, he would have intrusive images of somebody trying to attack him. And he would have to do all these mental compulsions to protect himself from the being attacked, which he found to be incredibly distracting from being able to have sex with his wife. Can you imagine what a bummer that would be? So we reprocessed the experience, and then we, this may sound a little weird, but we had him picture having sex with his wife in the session. And, just imagine it going smoothly with your positive cognition in mind and not having the intrusive images. So we did that a few times until he felt like he could do it. Then we had him purposely call up one of the intrusive images of the attacking thing, and he didn't ever really tell me exactly what it was, I think because, again, the shame and embarrassment. And that's one of the nice things about OCD is we don't have to know all of the details. So we had him imagine it with these things attacking him and mindfully refocusing on the pleasure of having sex with his wife. And we ran it several times. Then we had him go home and try it out. And then he came back and we had to actually retarget, but then we were basically able to get rid of the symptom. So it was really helpful. Yes?
We have a question about what was the author's surname? David who?
Yeah, so the question about the author's surname was David Sedaris, Sedaris.
Thank you.
One of my favorite books by him is Holidays on Ice, where he writes about being a Macy's elf during Christmas time. And the elves go take a break around the corner and swear and smoke cigarettes. It's just, he's very funny. He's a very funny author. Augustin Burroughs, who wrote Running with Scissors, also has OCD. And he does a beautiful description of magical thinking in one of his books that I think the whole book is about magical thinking. Because that's an OCD trait that people have, which is where they have this magical thinking. Like one of the things that people have is, okay, so there's a drop of water here. So I touch this water, and then I touch this hand. Then this hand touches the pants, and then the pants touch the car when I get in it. So guess what? The car is now contaminated from that drop of water. And it might not even be a drop of water. It might be a microscopic, imaginary speck of feces, So they have all these weird magical thinking things. And it, it can be really, it is something, again, we want to ask about. Do you have any magical thinking? So we had a question in the back first, right? Oh. Who was the author? Oh, the magical thinking. That's Augustin Burroughs. Burroughs, right? Yeah. He wrote Running with Scissors, and I'm blanking on the magical thinking book. But he's also just laugh till you cry funny. That's the other thing about OCD that's just a little side note that I love. So guess what? It's a genetic disorder. 1 in 50 people have it. So it's genetically selected for. Why would it be genetically selected for? It's not like sickle cell anemia, where they have a sickle cell that protects them against malaria. It's selected for because there are other OCD traits that are excellent. One of them being imagination and creativity. And I always talk with my OCD folks about using their OCD powers for good as opposed for torturing themselves. I have a friend with OCD. They moved into their new apartment, and I went to visit them a week later. It looked like they had lived there for 5 years. Everything was in order, and she said, oh no, I had it all planned out before I even moved. I knew where everything was going to go. I instructed the movers exactly where to place it. We used a level to level all the pictures. And boom, it's not like most people where they move in, they unpack a box, and, we haven't put up any pictures. It's been a year and a half. I have clients who are city planners and artists and authors and musicians and biologists and people who do all kinds of amazing things. So, it's not all bad. It's just the symptoms that are bad. The other trait that goes with OCD, which also can be a good trait, but people with OCD carry it too far, is what's called scrupulosity, which is where they feel like they have to do everything the exactly correct or morally upright way. And that often makes for a very upstanding citizen. The problem is when it's like my lady with the priest temptation, it was torturous to her. It was really hard for her. So that's one of the things we may have to directly target is scrupulosity. And we might have people do something a little wrong. With the OCD, there's the OCD Foundation. It's the OC Foundation. they have a conference every summer and they do a little camp because it's a conference where sufferers and clinicians can both go. And they do this thing where they run around and like kick people's tires and, you know, leave a candy wrapper on the ground. They, you know, do minor infractions to go against the scrupulosity. We don't want to do anything that's like inciting like severe, breaking of the law or anything like that.
Full towels the wrong way.
Yeah, full towels the wrong way. Yeah, and we do that too. I had a client who, he had this really bad, and so we decided to call him Mr. Messy, because he would come in and he was just, impeccable, you know, every hair in place, you know, the shoes perfectly tied, everything. So we would have him like, okay, for the rest of the session, you're going to untuck your shirt. And then we had to reprocess it because he would get so anxious. So we'd add the bilateral stimulation. And then by the end of this, you know, the session, he'd be much more calm with it. And we'd say, okay, this week you have to go to work with your shirt untucked. You know, you'd have to make him messy, you know, or you have to go without shaving for a day, you know, something like that. So we may not be able to reprocess all targets in one session. You have them imagine the stimuli like coming across blood on a razor with the positive cognition in mind, or see the trigger for the compulsion. Like we had one client where the number 6 was problematic, you know, because 666 is home of the devil or home of the beast. So we had her visualize the number 6. Then we had to visualize 3 number 6s. And then we had to send her to do homework. So the only time she could do her homework was when she was riding the BART, which is the local public transit. So she'd be sitting there on the BART writing 66666, you know, and the people next to her were probably thinking like, what is that lady doing? Okay, so the reevaluation phase, you have the client keep a log of obsessions and compulsions. And particularly, you know, I would check in about the thing they've been working on. So how, you know, what happened with the stove checking this week? Were you able to avoid checking the stove? Were you able to postpone? Were you able to call it OCD? You know, what basically were you able to do? And then anything that's a problem, we want to retarget it. Because of the biological nature of OCD, you might get some bounce back. So, you know, we used to call it whack-a-mole, which is that there's this game where they have these like moles that pop up and you hit one and another one pops up over here. So because of the biological nature, we may have to keep retargeting a little bit. That's okay. And you want to we really want to increase hope with our clients. So we want to emphasize the neuroplasticity and that the brain is going to change. And as we continue to work overall, you know, like we may be playing whack-a-mole, but slowly we're going to get the symptoms down and down until they're going to be able to get their life back. The other thing we can add in a future template is doing non-OCD behaviors. So for example, if the person has some elaborate ritual for doing the laundry, one way to do the future template is to say, just throw everything together in the dryer, pull it all out together, and then throw it on a heap in the bed, which is like, that would be against their ritual that they're doing. But another way to do it would be to say, instead of doing laundry all day every Saturday and spending hours and hours on it, go to the park and they get anxious about that. So we have to reprocess the anxiety about skipping the ritual. But that's also very reinforcing because once they get over that anxiety hump, they're going to be enjoying their life a lot more.
I have a client who has tics. He has some other OCD components, but the tics and the jaw seem, and his tic is
Oh, I'm sorry.
kind of the moving of the jaw.
Uh-huh.
How would you target that if he's not aware of a particular thought that's driving it? It's just a tic that happens? Do you know what I
Okay,
mean?
so the question is about a tick, and how do you target if they have a tick that's somewhat unconscious? So there's a couple of different things you can do. One is you can actually target, like sort of do a future template. And you can also do when did it first start, when's the most recent time, reprocess all of that. Then do a future template at times when they would be triggered. So sometimes the tics are random, and sometimes they do them more at certain times. So for example, I had a client he would slap himself in the face every time he sat down at the typewriter. And this is a long time ago, obviously, because we don't do typewriters anymore. But he would slap himself in the face every time he sat down at the typewriter, and he was a writer.
Problematic.
Really a problem. So we would, one thing we would do is do the future template of him sitting down and not slapping, not ticking. And then another thing you can do with tics is called massed practice. MASSED. So you have them do the tick over and over and over and over again until they kind of wear themselves out. And you can add the bilateral stimulation while they're doing it. So I guess it'd be hard to do with eye blinking, because you can do the eye movements, but you could do the tactile. Or you could do with, what kind of tick is it?
It's like a jaw.
A jaw. Yeah, so you can do,
Jaw goes sideways.
you go, while you're doing the actual bilateral stimulation.
Oh, I like that.
Yeah. Tics are hard, but they can be improved. Yeah. Yes.
I have a client that she's a hairdresser, and at one point when she had a client, she had to run to the bathroom because she had diarrhea. From there on, obsessive thinking began. There is obsession in the family. There is a background of a lot of anxiety. Every time before they had to go to a restaurant or anywhere, the thought will be, what if I'll have diarrhea? And she right away gets cramping and she has diarrhea. We got to a point where she's able to okay, what if, and calm herself down with tapping, but the thought keeps coming back, what if I'll have diarrhea and I won't make it to the bathroom? And she has physical reaction. She has
So
that
that's
stomachache.
sounding like irritable bowel syndrome.
The doctor sent her to me. She was tested. She doesn't have any physical issues.
Okay,
Not-
so irritable bowel syndrome is not necessarily physical. We think of it as panic disorder in the bowels. So it's more in the range of panic usually. But you would just...
But it is going with an intrusive thought. When she doesn't have the thought, she's fine.
Yeah. Well, that's really common with IBS. It's really common. But regardless, you would target it the same way. So you would do the first time of when she was working on the client and she had to run to the restroom,
You would get that.
and then the worst time, and then the most recent time. And with that sort of a symptom, we also would add in the somatic piece. So I have a client right now that I'm working with IBS. So we brought in a healing image for the actual, getting gas and diarrhea and those lovely things. And it was amazing because guess how many sessions, you guys? 2.
Wow.
He's had it for, 25 years or something. And just by adding in, so what he does is he has the healing image whenever he feels like he's going to get IBS, or, when he's going to have diarrhea or he's having stomach problems. And it's usually tied to anxiety. He gets anxious and then it happens. And it may be a thought as well, but he basically doesn't have it anymore. It's really neat. Yeah.
What was his healing image?
He's really into the mountains, which is interesting because I usually think of a healing image as being like my immune system or a healing light, but he had a mountain. People have all kinds of funny things.
Hi.
Hi.
Since we're talking about bowel movements, I thought I would bring in I have a client who has the opposite issue. She has been constipated since she was, a baby. there is nothing physically wrong with her. She goes to lots of doctors, mom OCD, sister OCD. It's almost like my client is OCD with inside of her body. Like she doesn't have rituals. She has some phobias. So I'm just curious, would you have a somatic experience of like this tightening and this anxiety? Do you have any recommendations about targeting that?
Just, I would use the basic anxiety protocol. So the first time, the worst time, the most recent. But the other thing is with someone like that, you want to get on board some of these self-control procedures, like the progressive muscle relaxation, breathing, because those are going to help calm the body.
Okay.
You know, and having an image, that is going to be related to relaxing the bowels and going.
Okay.
You know.
I'm still trying to convince her that there's nothing physically wrong with her because she's really attached to that.
Well, I am opposed to the idea that there is either a physical or an emotional illness.
Yeah.
I don't really agree that there's such a dichotomy in our body.
Yeah.
Because guess what? We have 100 million neurons in our gut. It's another brain down there that is directly connected to this brain. However, this gut brain knows a lot of stuff that this one doesn't.
Yeah.
So I used to get doctors who would say, I've got this lady, there's nothing physically wrong with her. And then, lo and behold, we found out later there was, for example, we're going to be talking later about the microbiome. I know I keep teasing you with that, but like the microbiome is, we have tens of trillions of bacteria that are in us and on us. We know almost nothing about what that is, and it's hugely, hugely important for our functioning of our emotions and our body and our brain and our immune system and everything else. It creates hormones, it produces genetic material that interacts with our own. There's all these things we don't know. So I hate to say this isn't physical, to people, because it's all physical and it's all emotional. That's kind of what I would say to people, and it often is reassuring to people when we
Yes.
produce it, that kind of, we talk to them about it that way.
And I agree with you. I think she's been on so many rounds of antibiotics. I mean, it's almost like she obsessively
Oh no.
goes and gets treatment. Like she wants to get a colonoscopy bag. Like she's just so.
Yeah, the antibiotics will
am.
make her sicker. So
Yeah.
we'll talk about that
But,
in a little
but
bit.
thank you for
Yeah.
that's mine.
Okay.
I have 2 questions.
Okay, 2 questions from the web folks. Hi, web folks.
Can you repeat what the exposure response graphs shown at the beginning of the OCD lectures are saying?
Okay, so the idea is when someone has OCD, if this is anxiety here, and this is time, at the bottom axis, when they start to obsess, oh, I didn't wipe well enough, I'm covered with poo, their anxiety goes up, and so then they go back and they do their compulsion. They wipe. So when they do the compulsion, the anxiety goes down, but the fear goes up, and they get more anxious. And then they wind up in this anxiety triangle of always feeling anxious and doing the compulsion. Okay, how's that? Okay. So then what happens when we're doing the treatment for exposure and response prevention is we have them not do the compulsion, allow the anxiety to rise, and they'll get very uncomfortable. It's very unpleasant. So you can't wipe. You just have to go to work with poo in your pants. Sounds horrible, but I mean, it's really microscopic, right? It's not really there. It's not like they have a big old hunk of poo. So, can't do the compulsion. Let's change to a more lunch appropriate since it's almost lunch. So, I check the stove. So you can't check the stove and you get very anxious. The house is going to burn down. It's going to be all my fault. They get very anxious. The anxiety peaks and comes down. The next time they don't check the stove, the anxiety peaks sooner and comes down sooner. And it keeps getting a little easier until pretty soon it doesn't bother them anymore. So then they're able to not check the stove. So that's the exposure and response prevention. And then what we think is happening with EMDR therapy is more the anxiety rises when we're doing our bilateral stimulation. It peaks and then it comes down really fast and stays down. And then the next time it'll peak way sooner and come down way sooner. And it gets, so pretty soon it just goes away.
And that is with the traditional exposure and response prevention.
This
or
is-
last BLS.
This is EMDR. Yeah, it's we don't call it exposure because it's EMDR, and we think that reprocessing is happening. So we call it response prevention with EMDR. Okay, it's a different, you know. For those of us who are trained in exposure, we kind of have to, you know. I'm sorry, Dr. Foa. I'm sure she'd be really pissed if she heard us talking about this because she's.
Tell her that
It's her thing.
specializing in EMDR.
Yeah, but it works. It's amazing. Okay, more.
One more question. Is it possible that reoccurring suicidal ideation is an obsession and treat as a symptom of OCD? No known diagnosis, however, of OCD.
So suicidal ideation, is that a diagnosis of OCD? So that needs to be very carefully evaluated, right? Because we don't want people committing suicide. So like my young lady who came in who was obsessed with hanging herself, I was like, oh no, you know, this is really a little nerve-wracking. I need to, you know, I don't want to like send this lady home and say it's nothing if it's real. In her case, it was OCD. It was very, very definitely OCD. There may be people where they have this intrusive thought of suicide, and that's often related to, for non-OCD people, they have this kind of fantasy about it. It's actually what Marshall Linehan calls the escape plan. You know, like, oh, if I just could commit suicide. It's kind of like, did anybody ever read Tom Sawyer? Where they are presumed dead, and then they go and they go to their own funeral and hear everybody talking about them, and they really enjoy it. You know, in the book with Tom Sawyer, they're like, oh, you know, they're talking about what amazing kids we were and all these things. So some people, it's that kind of a fantasy, you know. And there's some people that are just in so much pain with their whatever their emotional problems are, that it's like, oh, this is the only way out. And it's really important for us to educate about that and say, no, it's not an escape. In fact, we have no evidence that suicide is an escape or makes anything any better. It's an exit plan. And if you really need an escape plan, then you need to have an escape plan, like going out on disability or getting out of your abusive marriage. Or I had one client who was chronically suicidal for years. He didn't actually attempt, but he thought about it 24/7 because he had never filed his taxes. And he thought he was going to go to jail. He had all these weird ideas about it. So it took a lot of convincing, but I convinced him to call a tax attorney. He called the tax attorney, and he had to pay $53 a paycheck. And that was the only consequence to 18 years of never filing his taxes. Because he had been owed money for many, many years by the IRS.
This brings me to the thing that I've been asking about how to quickly differentially diagnose between OCD, eating disorder, OCD, actual suicidal ideation, OCD. Like, do you have a series of instruments that maybe you use, like a decision tree?
I am really not one of those people who can use decision trees. I'm not very good at them. I find them confusing. Basically, you know, I think this is there's a couple of things. OCD is ego dystonic, you know, so it's not you, it's not real, and they know it on some level. Now, eating disorder, that's a little tricky because there's high comorbidity between OCD and eating disorders. I used to run an eating disorders group for quite some time, and most of the clients that I had with eating disorders had OCD or something that really looked like OCD. These food on my plate can't touch, and it can't do this, and it can't do the other. You know, it was very OCD-ish, you know. So there really are, you know, can be kind of like kissing cousins. And then is it really suicidal ideation? You know, we had this terrible situation in the intensive outpatient program that I worked in where we had 1 year, just this very acute bunch of people, and we lost a lot of our patients. And the team was horrified. I mean, it was really a terrible, terrible situation. And then we all went and got ourselves trained in doing a really top-notch suicidal assessment. You know, so I think that, you know, that is part of doing our homework of how to do a suicide assessment. And that's another, you know, big long topic. But, you know, with OCD, generally what happens is they say, I think about it, I'm not interested. You know, I just started school, I'm really interested in this, I have a boyfriend, I'm having fun, really enjoying things, and these intrusive thoughts just keep coming and hanging myself. As opposed to someone who's like, I just can't bear this anymore. I can't bear this anymore. I have to stop, you know, living because this is so painful. Yeah. So that's kind of how I think of it. Is there a follow-up question on that?
Well, it's the thing about, maybe because I work in a really, really tough situation sometimes where you're just not sure if it's a trauma response. It's just like the distinguishing variable. If ego dystonic is the prime characteristic, that's really helpful to know.
Yeah, I always think of people with OCD is that on some level they know it's not real. This woman with the hanging, it was very interesting because we did EMDR therapy, and because she had this weird dovetailing of being a shameful Catholic about sex and incorporating these kind of strangulation behaviors into her masturbation and sexual practice. We started doing the EMDR with the intrusive hanging images. So she would have these intrusive hanging images, which were, she could tell you, those are not real. You know, like, I don't want to do that. It just keeps popping up. So we were targeting that, and all of a sudden, it switched into the sexual arousal stimuli. And she's like, I'm feeling kind of hot. You know, and what do we do with the EMDR when something like that comes up? We'd say, go with that. And she's like, ooh, yeah, now I'm really feeling hot. I'm feeling almost kind of like aroused, she said. So I said, oh, okay. I said, go with the arousal feeling. Notice that. And then she said, now I'm feeling really kind of like sexually aroused. And I said, you know, do you ever play around with kind of a little, you know, people do that. I said, do you ever play around with a little, you know, like choking as part of your sexual play or anything? And she turned beet red and she said, yes. And I've never told anyone, and I'm horribly embarrassed. And then the whole Catholic thing came out, and, you know, and it came out in the middle of the EMDR session because she didn't tell me because she was ashamed. And that was the interesting thing, that it was all tied up together. So there was the OCD part, and then there was the sexual practice part. And so we actually were able to decondition the sexual practice part so that she no longer needed to do that as part of her sexual practice.
So
Yeah.
how were you able to do that?
By targeting it with the MDR therapy.
Oh, just by what you were
Yeah, just by targeting it. Yeah, and then we gave her the hands behind your back protocol, which is from my dad, which he did for sexual deconditioning, is don't masturbate to it anymore. If you don't want to have something that's an unwanted sexual desire, stop masturbating to it and masturbate to a stimuli that's better for you. So we did that.
And you never went down the trauma, I mean, I would have gone to, is there
Of
is there
course,
traumatic sexual
of course we went to the trauma. And guess what? Complicated patient, there was that too. Yeah. So I mean, people are not always falling into neat, tidy categories, right? They can have more than one thing, and that's the hard part, right?
This makes it hard, but I wanted to address the eating disorder and trying to distinguish what's going on. What I think in working with any kind of issue like an addiction or an eating disorder is that they actually have lots of things that are going on, just like Priscilla was saying, but also they have distinguished types of issues with eating disorders that you can learn about. If you work with eating disorders a lot, you probably know it. You have to make sure that they are eating. You have to ask them very specifically, what are they eating? You have to talk about food all the time. And when the OCD comes in, it's in the way about, it comes in like, I wake up thinking about food, and I think about what I should eat and what I could eat and what I am going to eat. And then I go and I get that, and then I start worrying about, oh my gosh, I shouldn't have eaten that, I shouldn't have had that. So then I'm going to go into restriction mode. Or they're going to continue to eat all day, and then at night they suffer about it, they dream about it, they wake up thinking about it again. I call that a little slice of hell. That an eating disorder is like living in hell because you have no release, right? There's no respite. So I look at it as a component of an eating disorder. OCD is a component of the eating disorder, not as the main thing. In fact, Priscilla alluded to this earlier, but I believe also, and I wish I had a little more OCD, but I think that we all have levels of all the disorders in the DSM-5, and aren't we glad? Because they're all useful to some extent. But yeah, I discovered that way before they even were making the connection with eating disorders in the hospital and what people were thinking, and it kind of blew my mind, you know? So you can think about it that way, and then also just go the normal route. And if you need consultation or a decision point of what to do with the person, then talk to somebody who's been doing it forever. If you haven't, they'll be able to help you. And when to hospitalize and when not to hospitalize and all of that. But that's all I wanted to say.